Hey everybody, so we're going to go over the last chunk of stuff that is covered for your normal first exam. So we might go a little bit further than where you would normally go. So this would be starting on page 51 with your ribs. Yeah, so 51 to 54 with the ribs. Starting with your typical ribs, so definitely know that ribs 3 to 9 are your typical. Know that all of them have a head, a neck, and a corpus. A corpus is an AKA for the body, so they all have a head, neck, and body. All of your typical ribs 3 to 9, are going to articulate with two different vertebral bodies, so that's why they have the superior and inferior articular facets on the head, and then the interarticular crest is going to divide those two facets. So if a rib is only articulating with one vertebrae, then you would not expect all of those three features on the head. So hopefully that makes sense. A typical fill-in-the-blank style question about ribs is to name the three features that all ribs share, and the answer to that would be head, neck, and body, or corpus. Every single rib has those three features. All right, moving on to the atypical ribs. So atypical rib 1, you can see from the diagram in your book on page 52 that it is quite unique. It looks very different. It's short, it's stubby, and it has some special features, so you're going to want to know about those. However, it does still have the head, neck, and the corpus, or body, so remembering that those are the three features that every single rib has. Remember that on T1, you have that superior articular facet that articulates with rib 1, so rib 1 only articulates with a single vertebrae, which is why it has a single articular surface and no other features on the head. As far as the body goes, that's where you're going to want to know the features. So the mnemonic is ATV, so like that, and know the directions. So the A is going to be closest to the head of the rib, and then the V is going to be most distal. So A stands for artery, so that's going to be that groove for the subclavian artery. T stands for tubercle, that's going to be your scalene tubercle. And then V stands for vein, which is your groove for the subclavian vein. So just remember ATV from closest to the head to furthest from the head, and you will have that sorted. So that's a really common test question regarding the ATV on rib 1. Moving on to the other atypicals, so we got rib 2. It also has a lot of different features. If you remember, the bottom part of the vertebrae of T1 and the superior part of T2 are going to have articular demifacets, costal demifacets for that rib 2, so it has two articular surfaces and that crest that goes in between. So one of the unique features on rib 2 is going to be that tuberosity for the serratus anterior that sits on the upper surface. If you were doing your lab exam, or if you do wind up doing a lab exam later, it's a very, very distinctive feature around the angle of the rib, and you can't miss it. So always associate that tuberosity for the serratus anterior with your rib 2. Rib 10, if you remember from the last PowerPoint presentation, is so variable that we don't even cover it. It'll be mentioned a couple of times, but anything that seems to be very variable happens with rib 10, so we don't talk a lot about its special features. Ribs 11 and 12, however, are smaller floating ribs down at the bottom of the rib cage. They do have some features that we'll talk about. So again, they have the same head, neck, and body. Rib 12 and rib 11 are kind of distinguished by the ends. If you look in your book on page 54, you can kind of see in the diagrams that rib 11 has a bit of a boxed off end, whereas rib 12 has a slightly pointier end, but you can also notice a definitive tubercle that may or may not be present on rib 11 that will not be present on rib 12. So they look very similar in pretty much every other way other than the very tip and end of them. So again, that very classic question is what 3 features are present on all ribs. So you should be able to write these out, know them inside and out, and it's going to be that head, neck, and body. Every single rib has a head, neck, and body is an AKA for the corpus. So whichever one you want to write is correct. Moving on to the basic arthrology, that's going to be page 55 to 57. Now there's a lot of words and a lot of boxes and lists, so I tried to organize it in a way that hopefully makes sense for you. So if you're a chart person, this helped me a lot. We have the 3 different types of joint classifications on the left. So you're going to want to know all of those and what they represent. So this is a bit of a review from your Phys 1. So the mnemonic we used is SAD, S-A-D, for synarthrosis, amphiarthrosis, and diarthrosis. And then ISM, so SAD, ISM. I standing for immovable, S for some movement, and M for ample movement. So if that works for you, that's great. If not, I kind of just liked SAD and then knowing that the S is not movable, and then as you move down, A is more movable, and D is freely movable. So use whichever one you like. So next to each of the joint types, we have some of the features of them. So know that synarthrosis is a fibrous joint and it has no joint cavity. And then the classification under it is going to be a syndesmosis. So remember how we talked about those spinal ligaments being classified as amphiarthrosis syndesmosis? So that's where things change a little bit. So you also have a synarthrosis syndesmosis, and that is going to be immovable. Moving into the amphiarthrosis, so we've got a few different types here. You've got your cartilaginous, so that's going to be your synchondrosis, your symphysis, and your syndesmosis, which is going to be your spinal ligaments. So syndesmosis should be its own little feature there. But definitely know that your spinal ligaments are classified as amphiarthrosis syndesmosis. So your ALL, your PLL, your ligamentum flavum, those are all classified as amphiarthrosis syndesmosis. And that is something that Mr. Mortar likes to test on. So definitely know that. Moving into the freely mobile joints, you've got your diarthrosis. So those are your synovial joints. That's an AKA. A typical fill-in-the-blank question is to list out the 4 features that make up a synovial joint. So that's going to be your fibrous capsule, your synovial membrane, your minimum of 2 articular cartilages, as well as synovial fluid. So those are the 4 things that are required for any true synovial joint. And then obviously with the joints that move a lot, that's going to be types of joints that we work with a lot as chiropractors. So we want to know a little bit more about them. So they're under the 3rd column there. We've got all the different types of synovial joints. So you're going to want to know the names as well as the AKAs, and then definitely know some classic examples, particularly those found in the spinal column. So for our plane or arthrodial joints, I always put my 2 hands together and rub those up and down and think of that as a plane joint. So flat palms, put your palms together. That's going to be the way your zygapophyseal joint, so your facet joints on your vertebrae, that's how they're going to articulate. A hinge is aka is ginglymus, which I can never say. Pivot or trochoid, so your median atlantoaxial joint is going to be a classic example of that. So the median is very important to add there because there's also lateral atlantoaxial joints, which are going to be parts of your zygapophyseal joints. So only the middle part of that AO joint is a trochoid. And then for the saddle or cellar joint, our joints of Luschka are going to be modified saddle joints, so definitely know that. And then your condylar or ellipsoidal joint, your atlanto-occipital joint is going to be a classic example of that. Right, here's just a little chart that I wound up writing out for myself just to help me remember what was what. If that helps you, then I would write it out as well. Okay, moving into the regions of the vertebral column. This is where the book really starts to repeat itself. So we've gone over some of the general features, and now we're going to dig into some of the more distinctive features of parts of the vertebrae. So a lot of what you've already learned about the vertebrae it's gonna come in handy, but it's also gonna pull some of the pieces together and things will start to make a lot more sense. So last trimester, Mr. Mortar wound up ending the exam 1 material here, but every other exam has gone beyond. So I at least want to get through this a little bit and hopefully help you out. So on the very first paragraph, if he hasn't talked about 2Ma3, he will, and this is typically a bonus point on the first exam. So hopefully it is for you as well. This has almost always been a bonus point. So when we were talking about the different parts of the vertebral column, we mentioned how the cervicals were the most stable throughout the animal kingdom, where most animals have 7 vertebrae. So 2Ma3 is the mnemonic that Mr. Mortar has made up for the animals that do not fit that criteria. So the first 2 letters, the 2 and the M, letters and numbers, have fewer than 7 vertebrae. So you can kind of draw a line right down the middle of that Ma. And then A and 3 have greater than 7 vertebrae. So typically he'll ask you to write out an animal who has greater than 7 vertebrae or less than 7 vertebrae. So the 2Ma3 comes in handy. So 2 stands for two-toed sloth, and M stands for manatee. Both of those have 6 cervical vertebrae. A stands for ant bear, and 3 stands for three-toed sloth. So the ant bear has 8 cervical vertebrae, and the three-toed sloth has 9 cervical vertebrae. So a lot of variation amongst sloths. So if you're doing animal chiropractic and come across these types of animals, this would be important to know. But all other animals will have 7 vertebrae. All right, other than that, remember that your typical vertebrae are those C3 to C6. Know that the typical shape of the vertebral body is rectangular, and know that they tend to increase in size slightly from C3 to C6. A little note at the bottom of page 59 is important to recognize that the height of the vertebral bodies in the cervical region tends to decrease with age, but as the height decreases, the circumference expands. So they kind of pancake in a way. They get a little bit shorter and a little bit wider as we age. All right, so on page 60, there's a whole ton of words, and this slide kind of nicely summarizes what's important about it. So what it's talking about is the shape of the vertebral body and how it's responsible for making that cervical lordosis that we know is important. So the vertebral bodies themselves are shaped have a wedge shape to them. So from the diagram, my little PowerPoint made diagram on the left, they have their posterior height is greater than their anterior height. So if you have a bag of bones and you try to stack those bones on top of one another, they kind of tilt forward and they would create a kyphotic curve naturally. Obviously, we don't want a kyphotic curve in our neck, so what comes in to make up the difference? So that's where our intervertebral discs come in. So the discs are also wedge-shaped, and they have the opposite dimensions. So their posterior height is smaller than their anterior height. So the discs are exclusively responsible for creating that lordosis of our neck. So that's where disc health is very important in maintaining that lordotic curve of the cervical spine. So we know that that lordosis has to come to an apex and then kind of curve backwards. So that second point, knowing that the intervertebral discs are wedge-shaped, they form that curve, but know the regions. So C2 to C3 intervertebral disc to C4, C5, that height is going to decrease, and then lower down, that height increases. So that's going to help, again, with the lordotic curve. But most importantly is knowing that in the vertebrae, in the cervical spine, the vertebrae themselves are going to create a kyphotic curve, and the intervertebral discs compensate for that, and they are exclusively responsible for creating that lordotic curve. And as we go through this kind of repetitive information, you'll see that the same is not true of the thoracics and the lumbars, which is why it's important to recognize what is special in the cervical spine. Okay, so if you haven't gotten to this yet, that's probably great, because the way it's explained in class can be very confusing. But hopefully with PASS, it will help to clarify things before you have a chance to get confused. So we go through each of the vertebrae throughout the spinal column, and we talk about the joints on the vertebral body, the synovial joints, and so on and so forth. So I'll tell you what the important features are. You're going to go through and count all of the joints in class. However, what's important to know is the overall numbers. That's definitely more of an exam 2 thing. So I've made a chart for you in exam 2. So for right now, I'll just tell you the important things to remember that may or may not come up on your exam 1. So when you start thinking about the joints on the body of a typical cervical vertebrae, think of what's right on top and right on the bottom. So there's going to be 2 joints there. Those are going to be your superior and inferior intervertebral discs. So 2 symphysis joints. So we've got 2 on the body right now. And then on your ALL and PL, so for your ALL and PLL, remember those are amphiarthrosis syndesmosis joints. That's where that diagram on the right comes in handy a little bit to recognize that there are 2 articulations for each of those. So sometimes we think of the ligaments as just kind of one just being plastered against the vertebral body, but that's not actually the case. So they articulate at the top of the vertebral body and at the bottom of the vertebral body. So each of those amphiarthrosis syndesmosis joints occur in 2 spots, 2 for the ALL and 2 for the PLL. So we've got 4 ligamentous joints on the vertebral body. And then we've got our joint of Luschka. Remember, that's going to be formed by those oncovertebral joints, which is a modified sellar or saddle joint. So remember your uncinate processes, which are the goalposts. Your uncinates go up and the lips go lower. So your uncinate processes are going to articulate with the lateral grooves, and that's going to help form that joint of Luschka. So you've got 2 above and 2 below. So articulating with the vertebrae below and the vertebrae above. Remember, everything's connected. So that's going to be 4 synovial joints. Each of those are independent and unique. So the question then is, how many total joints are on the vertebral body of a typical cervical vertebrae? And the answer is going to be 10. 10. 2 symphysis, 4 ligamentous, and 4 synovial. Going into a little bit more detail about that joint of Luschka. So this is kind of an explanation on a point that's in the second paragraph of page 61. So the joint of Luschka is that oncovertebral joint. So first of all, again, think of those goalposts and think of what sits inside those goalposts. So your intervertebral disc is going to sit inside those goalposts. So one of its major functions is going to be to stabilize the intervertebral disc. And then again, if you put your arms up as goalposts, think of the way flexion. So move your head forward, touch your chin to your chest, go into flexion, and then try to put the back of your head onto your back. So go into extension. So those goalposts, those uncinate processes are going to move in that same plane. So it's not going to inhibit that flexion and extension, excuse me. However, when you lateral bend or you rotate, those are going to come into play. So we call the coupled motion the cheater's move, because if you think of how, if you were looking at your paper and for no good reason you were trying to look at your neighbor's paper, you'd have to tilt your head and also bring your chin down towards your shoulder. So that's coupled motion. That's axial rotation with lateral bending. So that's going to be where that uncinate process comes in to play there. All right, so there's a lot of information through these pages, but what do you need to know? So in the cervical spine, in those typical cervicals, C3 to C6, what attaches to the vertebral body? So you want to know that that longest colli muscle attaches to the vertebral body between C2 and C6. You want to know that the ALL and the PLL are also attaching there. For the pedicle, you want to know that the pedicle is directed and posterolaterally, which we already discussed when we were talking about the bony structure. So remember, posterolaterally about 45 degrees. And then moving further backwards towards your lamina, remember those are going to be directed posteromedially, so they're going to rejoin, and then where the two lamina articulate is going to be where that spinous arises from. And know that your ligamentum flavum, remember that's that posterior part of the spinal canal, is going to be attaching to that lamina. All right, then our vertebral foramen. So the hole that's formed by the neural arch and the body where the spinal cord traverses through. So we want to know its shape. It's heart-shaped or triangular. You want to know where it's the biggest. So C6, remember we talked about that when we were talking about where the spinal cord was the largest. So it would make sense that the vertebral foramen is going to have to be its largest there in order to compensate for that larger spinal cord. And remember that was because of all of those nerve roots required for the brachial plexus. C5 and C6 and C4 and C5 are going to be where the greatest frequency of osteophytes occur. So remember, osteophytes are that accessory bone formation and they're little bony spurs. So they might be completely asymptomatic, or they might be in a part of the vertebral foramen that could have some neurological consequences. If those osteophytes are projecting into the vertebral foramen or into the intervertebral foramen, we're going to have a bit of a problem if it starts impinging on nerve roots. So it's important to know that location right now, and then as we get into more motion of the spine, it will make even more sense because you need to know where the greatest area of flexion extension is, and that's going to most commonly be in that C5, C6 region, and then C4, C5 is the second most common. So where you have the most movement is going to be where you're most likely to develop osteophytes. Okay, moving on to the things you need to know about the typical transverse processes. So know that they are pointed forward and downward. Remember that soft tissue, that nervous tissue that forms the brachial plexus is going to kind of pull those TVPs down and forward. So the TVPs of the cervical spine are a lot more involved than those of the rest of the spine. So if you have your bag of bones or your disarticulated spine, look at those. Look at the costal element, the costotransverse bar, the anterior tubercle, the posterior tubercle, as well as that true transverse process. And just be able to differentiate them visually. And then as far as all of these muscles that are attached, this is what I would recommend. I would recommend knowing what's attached on the anterior tubercle, know what's attached on the costotransverse bar, and then everything else is attached on that posterior tubercle. Learn less to know more, because there's a lot of information and you already have a lot of information to know. So I think that the ability to rule things out is probably one of the best lessons you learn taking spinal anatomy exams. So your anterior tubercle is going to have articulations for the anterior scalene, the longus capitis, as well as that longus colli. Your costotransverse bar is going to have an articulation for the middle scalene. The transverse foramen, so that is the hole that you see, the very round hole that you see in the transverse process, and that is going to contain some features that are important to know. Certain parts, vessels and nervous structures travel through that area. So that's going to be where the vertebral artery travels through as it's going up towards the brain. The descending vertebral venous plexus is going to be held in that foramen, as well as sympathetic fibers. So do know this point. The transverse foramen is the most definitive way to identify a cervical vertebrae. So he does like little features, like questions like that, because he could ask you that simple question, what's the most definitive way to ID a cervical vertebrae? There would be transverse foramen as an option. The uncinate process would be an option. So other unique features will also be included, but the transverse foramen is the most important part to define a cervical vertebrae. And then remember, C6 is going to have that carotid tubercle as well on its transverse, and that is unique to C6, so important to know. All right, so remember that we said that the anterior scalene was going to be one of those few muscles that we should remember that attaches to the anterior tubercle, but where else does it have an attachment? And we talked about that with rib 1. So that's going to be articulating at that scalene tubercle on rib 1. Part of that ATV, remember. Okay, on to the articular processes. All right, and when you get to this is another part that can be really confusing in class, but rest assured, we have developed some awesome ways to help you get through it with Spinal Pass. So I want to start by drawing your attention to what's in purple. So the facets of the articular processes are in the coronal plane. That's really important because when we're moving the zygapophyseal joints as chiropractors, we need to know the orientation of the facets. So the cervicals are going to be in the coronal plane, the thoracics are going to be in the coronal plane, and then the lumbars, most of them at least, are going to be in the sagittal plane. So definitely know that. And then we start getting into the orientation of those facets. So what's important for you to know now is just that the superior articular facet is oriented backwards, upwards, and medially. So bum, backwards, upwards, and medially. And the inferior articular facet is oriented forwards, laterally, and downwards. So I know this is a really weird way to describe a facet. So if you have your bag of bones, try to look at the facets and try to make that work in your brain, because it seems like a lot of descriptive words, but what's important right now is to just kind of honestly memorize that, and then know that your typical cervicals have that bum fold orientation. And for exam 2, that's going to be a lot more important. So could potentially be a question on exam 1, but that's all you need to know. And I think that it is helpful to recognize how those articulations go together. So backwards goes with forwards. So those are going to be parts of the articulation that mirror each other. between the superior and inferior articular facet, so backwards and forwards. Those need to, in order for that plane joint to fit, one has to go backwards, the other must be forwards. And then upwards and downwards, think of those kind of going together, and medial and lateral. Those will be kind of reciprocals, if you will. If that confuses things, then just remember bum fold. Know what they stand for, and know that kind of as the mnemonic for your typical cervical vertebrae. Honestly, I know it sounds super confusing, but it clears itself up as you go along. And unfortunately, this is one of these things that we kind of just have to memorize. So as far as muscle attachments, again, I would not stress yourself out about memorizing every little thing, but I would know that both of the longissimus muscles, both of the semispinalis muscles, and the multifidi are going to be attaching at this articular process. And then if you flip over to the top of page 64, sometimes this is a little feature that gets kind of glazed over, but it has been tested on in the past. So you want to know what a meniscoid fold is. So when you think about the meniscoid fold, I kind of think of it like a bit of a loose bag. So it's going to be a modification of that fibrous capsule surrounding the zygapophyseal joint. So the thought is that it's useful in distributing pressure across the joint surface. Think of how those zygapophyseal joints move. They can't be totally tight in order to allow for that movement. So I kind of think of them like that. All right, moving along to the spinous processes. So you want to know that they increase in length from C3 to C6. And then in purple, these are some little factoids that Mr. Mortar really likes. He likes any kind of racial disparities or any kind of genetic disparities. So you want to know that they are typically bifid in Caucasians and typically non-bifid in African Americans. So two ligaments that you should know about are that interspinous ligament and then the ligamentum nuchae. So we'll talk about this a little bit more later, but the ligamentum nuchae is a continuation of the supraspinous ligament. So supra means on top of. So there's that small ligament that's on top of the spinous processes. It gets significantly thicker as you move up the cervical spine. So that transition actually happens from supraspinous to ligamentum nuchae at C7. And so that's going to be a great stabilizer of your neck posture. All right, so this will be the last thing that we cover before this exam, just to do our due diligence in case he kind of powers along in those first few days of next week. So at this point in the book, we start to talk about, we just talked about the typical cervicals. Now we'll talk about the atypicals, and then it goes into more detail as we go along. So we'll talk about C1. And remember, in the last PowerPoint, I mentioned how the AKAs were important to know. Again, this will likely show up more on the second exam, but no, obviously C1 is atlas, and we'll go through the AKAs again as they come up. So remember, importantly, C1 does not have a vertebral body. That's obviously an incredibly distinct feature. It also does not have an intervertebral disc between C1 and occiput, obviously, and not between C1 and C2. So that first intervertebral disc in our spinal column is going to be between C2 and C3. And that makes a lot of sense because if you think of the dens and how it sits up against C1, no disc would really fit there. So there's no disc between C1 and C2, which means our total number of intervertebral discs is only going to be 23. So important things to know about C1 or atlas. He likes you to know the proportions of the neural arch and what they're formed by. So you should know that the anterior arch is going to make up that smaller portion of the vertebral foramen and those equals that I have there. So the anterior arch is the homologue of the pedicle. You'll notice as we go through this course, Mr. Mortar really loves homologue. So you want to know what that what's associated there. So the anterior arch has a homologue. Its homologue is the pedicle, and it makes up about 20% of the circumference of the atlas. And then on the back side, we have the much larger posterior arch, and the posterior arch is going to have a homologue of the laminas. That's going to make up about 40% of that circumference. So definitely know those numbers. And then to complete the circle, if you will, the lateral masses are homologous with the articular pillars. So definitely know those homologues and the percentage that each part of the atlas or the features that make up the atlas are. All right, now we'll talk about more features of each of the individual parts of C1. So remember, anterior arch is homologous with the pedicle. So there's a very large anterior tubercle. All of those anterior ligaments of the vertebral column are going to have articulations there. So our ALL, our anterior longitudinal ligament, the anterior atlanto-occipital ligament, as well as that anterior atlantoaxial ligament. So that seems like a lot, but think of where those articulations go based on the names. Atlanto-occipital from the atlas to the occiput, and atlantoaxial from the atlas to axis. So one's going up, one's going down. Kind of makes sense that they would articulate there. An anterior longitudinal ligament, remember how that connected on the anterior part of the vertebral bodies of all of the other vertebrae. So there's no vertebral body. It would make sense that it's going to articulate on the most anterior surface of C1. So that would be that anterior tubercle. And then again, the longest coli could have a muscular attachment. Remember, the longest coli had an attachment on the vertebral bodies of all the rest of them. So it's going to find that most anterior point and articulate there. I will reiterate this again just because it's so commonly messed up. The fovea dentis is found on that anterior arch. The facet for fovea dentis, the longer name, is going to be on the vertebrae below. So C2 has the facet for that. So just keep drilling yourself on that. Don't get caught. And the articulation between the fovea dentis and the facet for fovea dentis forms that median atlantoaxial joint, which is that diarthrosis trochoid. Again, that's going to be 20% of the circumference. The lateral mass, remember, that's going to be homologous with the articular pillar. When we talked about the typical cervicals, remember they had bum fold, B-U-M-F-O-L-D, for their superior articular facet and inferior articular facet orientations. C1 is special, so it's going to be different than all the others, and its superior articular facet is still bum, B-U-M, but its inferior articular facet is BMD, so backward, medially, and downward. C1 is the only vertebrae that has a orientation, that BMD orientation, that is unique to C1 exclusively. Those facets are also asymmetrical. So when Mr. Mortar talks about them, he often talks about the peanut-shaped versus the elephant pad. So the superior articular facets are going to be those peanut-shaped, and the inferior articular facets are going to be that elephant foot pad. And I think that if he ever uses that analogy in a question, at least feet are on the bottom, and those elephant foot pads are also at the bottom. And those lateral masses make up about 20% of that circumference. Moving on to the biggest proportion of C1 is going to be the posterior arch. That is homologous with the lamina. It makes up 40% of the circumference and the posterior tubercle that's found on that posterior arch is going to be a homologue of the spinous process. So those numbers on the bottom of page 66 are drawn out in that diagram to the right, and those are important numbers. So you definitely want to know that the distance from the tip of the posterior tubercle to the surface of the skin is about 50 millimeters in males and about 37 millimeters in females. So that's if you were to drop down off your occiput, you can normally quite easily find C2 spinous process, but above that, you would have to be digging in about 50 millimeters if you're a male through that ligamentous tissue, or about 37 millimeters if you're a female, to try to feel that posterior tubercle, which is very hard to do. So those other numbers are actually found at the bottom of page 69. So the ones on the side of the circle are the distance from the transverse process, the posterior tubercle of the transverse process to the surface of the skin. So he's not normally very big on the decimal places, but know that's about 30 millimeters from the posterior tubercle of the TVP to the skin. And then across the circle, so that circle is supposed to represent C1, it's kind of circular shaped. So the transverse diameter, you want to know that it's about 78 millimeters in males and 72 in females. The features about the ponticulus posticus, so that's going to be discussed in that bullet point on page 67. You want to know how to spell ponticulus posticus for one. You want to know that it represents accessory bone formation due to ossification of the posterior atlanto-occipital ligament. If you were to come across something like that on your lab exam, you have to either refer to it as a complete or an incomplete ponticulus posticus, and know for your lecture exam that an incomplete ponticulus posticus is more common, and it is more commonly observed in females. And then only if it is complete does it have a technical opening. So if there's a full hole that's formed by the complete ponticulus posticus, that's going to be called the arcuate foramen, or aka the retroarticular canal, which there's some potential implication on compression of the vertebral artery. Okay, so moving on to myodural bridges, that's on page 68, and this is super, 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 super important. This would be on your lab exams, on your lecture exams. It'll be on all 3 lecture exams, so you want to know and pay attention to this. So myodural bridges are fascial extensions from certain suboccipital muscles. So they connect your muscles to the dura that surrounds your nervous tissue. So obviously these could be implicated in things like cervicogenic headaches. So they're very important for us to understand as chiropractors. So the 3 muscles that form these myodural bridges are the rectus capitis posterior minor, the rectus capitis posterior major, and the obliquus capitis inferior. So all of those suboccipital muscles, the only suboccipital muscle that doesn't is the obliquus capitis superior. So you definitely want to know those 3 that form myodural bridges. And definitely recognize that the obliquus capitis superior will be used as a distractor in these types of questions. So if you have to write them out, that's all well and good, but because they all sound so similar, if you have all of these in a multiple choice question, don't get stuck. I always think of all of the odd things with the suboccipital muscles occur with the obliquus muscles. So we can abbreviate the rectus muscles by RCPM minor and RCP major. So those 2 are pretty consistent. They do all the things. But the obliquus capitis superior doesn't form a myodural bridge, and it's located more superiorly, obviously. And then remember the obliquus capitis inferior I guess you wouldn't have gotten here in lab, but the inferior does not form part of that attachment to the skull. So, but we'll get there. So at this point, just know which 3 make up those myodural bridges. More on the TVP of C1. So know that those lateral bridges can form there, and they're connections between the lateral mass and the TVP. So in those diagrams in the bottom left, that's going to be the ponticulus posticus, and on the right, on the left, that's a complete ponticulus posticus. So you would see an arcuate foramen. And then on the right, you can see how this is completely oriented differently. So we have that lateral bridge, which goes from lateral mass to TVP. And when that is complete, it forms that retrotransverse foramen. So know that that has only been observed in humans. That's something that could show up, but mostly be able to differentiate between the two. All right, so this can be a little bit confusing about this C1 articulation, and it is brought up on page 68, just above the beginning of the T transverse process. So I just wanted to bring your attention to this diagram, just in case it shows up. So from the IVF drawings that we've done previously, C1 and C2 is unique. So whereas on typical vertebrae, the anterior boundary is formed by the vertebral bodies, but we don't have that on C1. So the anterior boundary between C1 and C2 is going to be formed by the zygapophyseal joint, so that articulation between C1 and C2. So that's very unique. That only happens in a couple of places, so you definitely want to know where that occurs. So C1, C2 is a special area where the zygapophysis forms the anterior boundary. And then the posterior boundary is formed by all those other things that are listed. So we got our posterior arch, our posterior atlanto-occipital ligament, and atlantoaxial ligament. Most important is to know that the zygapophysis is part of the anterior boundary on C1 and C2. But when we're looking at our typical IVFs, that is not the case. They're always posterior. Remember how we talked about like pre-zygapophyseal versus post-zygapophyseal and drew that diagonal line through. So I just want to bring your attention to that. I don't intend to confuse you at all. So hopefully that's not the case. All right, here's some Kahoots. So we got session 1, session 2, and a Kahoot for exam 1. Hopefully they are helpful to you. And I have found this Quizlet has been very helpful, and I've gotten lots of great feedback on it. So definitely use it. Reach out with any questions. Thank you.